Hey ladies, welcome to GOC Grace channel. It's time to explore more about your body. In just a few minutes per day, you can take control of your health and well-being. First things first, don't try to take care of your health on your own. Consult with a doctor for advice. Today, we will look at a health condition known as bleeding disorder. Bleeding disorders are a group of medical conditions that result in an abnormal tendency to bleed, either spontaneously or excessively in response to injury. These disorders can arise from defects in the blood vessels, abnormalities in platelets, or deficiencies in clotting factors, proteins in the blood that are essential for normal clotting coagulation. Bleeding disorders can be congenital, inherited, or acquired later in life due to other diseases, medications, or unknown causes. The severity and presentation vary widely, from mild to life-threatening bleeding, hemostasis, and the clotting process. To understand bleeding disorders, it's crucial to first understand the normal clotting process, also known as hemostasis. It involves vascular phase vasoconstriction to reduce blood flow, platelet phase platelet adhesion, and aggregation form a temporary plug. Coagulation phase activation of clotting factors leads to fibrin clot formation, fibrinolysis, breakdown and removal of the clot after healing. Disruptions in any of these steps can lead to excessive bleeding or poor wound healing. Classification of bleeding disorders. Inherited bleeding disorders. These are genetic conditions passed down through families. 1. Hemophilia, a factor VIII deficiency, X-linked recessive, primarily affects males, deficiency of clotting factor VIII. Severity classified based on factor activity: severe, moderate, mild. 2. Hemophilia B, Christmas disease, factor IX deficiency, X-linked recessive, clinically similar to hemophilia A, but involves factor IX deficiency. 3. Von Willebrand disease, VUDL, most common inherited bleeding disorder, caused by a deficiency or dysfunction of von Willebrand factor VUF, which helps platelets adhere and stabilizes factor V. Types. Type 1. Partial quantitative deficiency, mild. Type 2. Qualitative defects, various subtypes. Type 3. Total deficiency, rare and severe. 1. Other rare coagulation factor deficiencies. Deficiencies in factors I, fibrinogen, 2-prothrombin, V7, X, Xi, Z, autosomal recessive inheritance. Symptoms vary. 5. Platelet function disorders. Glanzmann's thrombasthenia, defect in platelet aggregation. Bernard-Soulier syndrome, defect in platelet adhesion due to Gib deficiency. Storage pool disease, defects in platelet granules. Acquired bleeding disorders. These arise due to other diseases, medications, or external factors. 1. Vitamin K deficiency, needed for synthesis of clotting factors 2, 7, 9. X causes include malnutrition, malabsorption, for example, biliary obstruction, prolonged antibiotics. 2. Liver disease. The liver synthesizes most clotting factors. Conditions like cirrhosis can cause significant coagulopathy. 3. Disseminated intravascular coagulation, DIC. Widespread activation of coagulation with consumption of clotting factors and platelets associated with sepsis, trauma, malignancy, obstetric complications. 4. Anticoagulant use. Medications like warfarin, heparin, or DOACs, for example apixaban, can cause bleeding. 5. Immune thrombocytopenic purpura, ITPAP, autoimmune destruction of platelets, presents with petechiae purpura, mucosal bleeding. 6. Acquired hemophilia. Autoantibodies against factor V. Occurs in elderly, postpartum women, or with autoimmune diseases. 7. Uremia, chronic kidney disease, can lead to platelet dysfunction. Pathophysiology. Normal hemostasis involves vascular constriction at the site of injury, primary hemostasis, formation of a platelet plug, secondary hemostasis, activation of the coagulation cascade to form a fibrin clot. Disruption in any step may result in platelet disorders, immediate mucocutaneous bleeding, for example epistaxis, gum bleeding, petechiae, coagulation factor deficiencies, deep tissue bleeding, for example hemarthrosis, muscle hematomas. Clinical presentation: symptoms of bleeding disorders, easy bruising, prolonged bleeding after injury, surgery, or dental work, spontaneous bleeding into joints or muscles, menorrhagia, heavy menstrual bleeding, hematuria, gastrointestinal bleeding, epistaxis, nosebleeds. Signs to look for: petechiae, pinpoint skin bleeding, platelet disorder, ecchymosis, larger bruises, hemarthrosis, joint swelling and pain, more common in hemophilia, hematomas, localized collections of blood and tissues. Diagnosis: a history and physical examination, family history of bleeding, personal bleeding history, surgery, trauma, menstruation, drug and supplement use, aspirin, NSAIDs, anticoagulants, associated medical conditions, liver disease, autoimmune disorders. B. Laboratory investigations. 1. Initial screening. CBC with platelet count. PT prothrombin time assesses extrinsic pathway factors I, 2, V7, X apt activated partial thromboplastin time assesses intrinsic pathway factors I, 2, V8, 9, She, bleeding time evaluates platelet function, rarely used now. Thrombin time, fibrinogen level. 2. Specific tests, factor assays V, 9, etc. VUF antigen and activity levels, platelet function analysis FA100, aggregometry, mixing studies. To differentiate factor deficiency from inhibitors, inhibitor assays, for example Bethesda assay for factor VIII inhibitors. Management: A. General measures, avoidance of NSAIDs, aspirin, and trauma, patient education, use of medical alert identification. B. Specific treatment: 1. Hemophilia A and B. Replacement therapy with recombinant or plasma-derived factor concentrates, prophylactic vs. on-demand therapy. Desmopressin DAP for mild hemophilia A stimulates release of stored factor VIII and VUF. Amicizumab, a bispecific antibody for hemophilia A. 2. Von Willebrand disease. DDAVP for type 1 and some type 2 variants. VWF containing factor VIII concentrates for severe cases. Antifibrinolytics, for example tranexamic acid, for mucosal bleeding. 3. Platelet disorders. Platelet transfusions for severe thrombocytopenia or functional defects. Immunosuppressive therapy for ITP, for example corticosteroids. IVIG, rituximab, splenectomy in refractory ITP. 4. Liver disease or DIC. Treat underlying cause. Fresh frozen plasma FFP, cryoprecipitate, or platelets as needed. 5. Vitamin K deficiency. Oral or for vitamin K replacement. 6. Reversal of anticoagulants. Vitamin K and FFP for warfarin, protamine sulfate for heparin. Specific reversal agents for DOSCs, for example andexanet alpha for apixaban or rivaroxaban. Complications: chronic joint disease, hemophilic arthropathy, anemia from recurrent bleeding, inhibitor development, neutralizing antibodies to factor replacement, psychosocial impact, anxiety, activity limitations, bleeding during pregnancy or surgery, hemorrhagic stroke, rare but serious. Prognosis: with appropriate diagnosis and management, many patients lead normal or near normal lives. Prophylaxis in hemophilia has dramatically improved outcomes and reduced complications. Lifelong monitoring and care from a multidisciplinary team. Hematologist, physical therapist, genetic counselor are often necessary. Recent advances in research. Gene therapy, promising results in hemophilia A and B to restore clotting factor production, long-acting factor concentrates, reduce infusion frequency. Non-factor therapies, agents like emicizumab, provide alternative pathways for clot stabilization, improve diagnostic tools, genetic testing, advanced coagulation profiling. Conclusion: bleeding disorders encompass a diverse group of conditions that can have profound clinical and psychosocial effects. Early diagnosis, comprehensive care, and individualized treatment plans are essential to manage these disorders effectively. Advances in therapy, particularly gene-based interventions, are paving the way for long-term solutions and potential cures for certain inherited bleeding conditions. Always remember to ask for help and support when you're struggling with any health condition. If you need additional information, don't hesitate to ask. See you on our next post.